This is a possibility in terms of the fading of the antibodies, but we won't know for quite some time. My suspicion is they do not last for life if we compare COVID-19 to other coronaviruses, such as the ones that come yearly with influenza season. Those tend not to last more than a year. So I anticipate antibodies from COVID-19 will last somewhere around 6 months to a year.
We have to keep in mind that with time will come more clarity, and we'll learn more and be able to see whether these are truly persistent throughout the community, or if they do just have a sort of delayed resolution. What we have seen, I think, is a correlation between severity of illness and likelihood of having persistent symptoms after resolution of the severe phase of the illness. So if you were going to categorize long-term effects, one of the things to keep in mind is to separate them into buckets of those patients who had severe illness and those patients who had less severe illness. For those patients who had less severe illness, typically they're treated as an outpatient. They have relatively mild symptoms, but the common persistent symptoms seem to be cough, shortness of breath, fatigue is a common complaint, and that seems to last sometimes for weeks. And generally speaking, the younger the patient, the faster the resolution. But again, severity of illness comes into play there. Even a young patient who's had severe illness can have some persistent symptoms. Perhaps not thinking clearly or having some cognitive impairment. That's a little bit more difficult to measure and follow. Certainly patients who have had severe illness, who have been intubated, who may have had low oxygen for a period of time, those effects on the brain function may persist for quite a while afterwards. So I think the bottom line is wait and see. But in general, the more mild the illness, the faster the resolution. There are a number of other organs that can be affected. For the lungs, for example, which is sort of the target for coronavirus, we do see patients who've had, again, severe illness with sometimes scarring of lungs and chronic, seemingly more long-lasting impairment of lung function. And only time will tell if that does improve with time. Cardiovascular function can be temporarily impaired. There is an inflammation of the heart muscles and the blood vessels supplying the heart. In some cases, that can cause temporary, usually, impairment of the heart function. And that can sometimes persist and cause fatigue or shortness of breath. I mentioned those as being common longer-term complaints. There are a number of other organ systems or organs that can be affected more typically temporarily for kidney function, liver function, sometimes adrenal function. And we have seen cases of diabetes that have been presumably induced by the immune response to the virus. That would be a long-lasting complication of the virus.
The COVID-19 could be compared to SARS because those are of the same family. In addition, it could be compared to MERS, or Middle Eastern Respiratory Syndrome, because that is also a coronavirus. It is not fair to compare it to Ebola, which is a completely different virus and much more virulent than the coronaviruses. So in general, I would compare COVID-19 to MERS and SARS versus Ebola.
We trend virtually everything here at the hospital. The numbers of patients that we have who are COVID positive, the number we've treated, our mortalities, the medications we've used to treat patients. So we follow those trends internally very closely. And more recently, for in-hospital patients, the numbers were certainly high in March, April, May, very high. We did see a resolution of that bump, and then another shorter or less voluminous bump of patients in the past 6 weeks. That seems to be now subsiding, but we always kind of go in 2-week looks at that data, because we know that the virus has an incubation period, and sometimes, as has been seen in Florida, for example, if a younger population is infected, which did occur in King County during this last surge, then a couple of weeks later we may see a surge related to that in an older population. So we're following those trends very carefully. We also trend both county and state data. Through the Northwest Healthcare Response Network, we look regionally, not just within our county, but up to Snohomish County and down to Pierce County and their numbers, and nationally. So we keep track of a lot of data, not just in-house, but we monitor everything that's going on in our vicinity and distantly even.
Overall, the data shows that we're seeing more cases, which I suspect is a result of increased testing of people in the community. In addition, there is probably some exposures of people who have not had it before due to the quarantining as society opens up. So that increase to me would not suggest a worsening of the pandemic, but more an accounting of those numbers. The other number I look at is the number of deaths and hospitalizations. The death rate and the hospitalization rate does not seem to be following along with the number of increase of cases. So at this point, it's reassuring to me that we're not seeing as many people die from the virus, and not as many people are not being admitted to the hospital. And if they are, they're not as severely ill as they were in the first few months of the pandemic.
So there are lies, damn lies, and statistics. And so you have to have a very critical eye when you look at any information. The first thing to consider is the source. Is the source reputable? Is it from an institution that's vetted and has access to accurate data? And can it be verified? So that would be number one. I would say also look at the denominator. What is the scope of the information that you're getting? Is it something that was a study of 5 patients, or was it a study of 5,000 patients? The larger the study, the larger the pool of information that you can draw on, generally speaking, the more accurate your information is. And then be aware of context, be aware of trends. For example, if we don't have a robust testing system in place, we may be missing some information. The mortality information, the rate of infection may be too low or too high. So a lot is dependent on our infrastructure and our ability to test and provide information in a larger group, larger community, to be able to pinpoint exactly how meaningful that information is.
So the R naught that has been discussed with a lot of epidemiologists and such is a mathematical calculation, but it's based on having all the numbers of cases and the number of people who are infected, the number of people who are asymptomatic, and the like. I think it's still very early to have a solid number, but with the preliminary data that we're seeing, the R naught seems to be anywhere between 1.2 to 1.5, which would not suggest a severely contagious virus. For example, measles R naught is around 16 to 18, so it is not as bad as measles.
So we are very fortunate to have been proactive throughout this pandemic, and we have not more recently experienced shortages of personal protective equipment for our staff, for our patients or their visitors. There have been delays in testing. However, we have I think 4 different platforms now that we can use to provide testing. Some of those are sent out to another laboratory, some of those we do in-house. And in general, we have not had a delay in our in-house testing. Some of the tests that get sent out because of the recent surge in demand, as well as the supply of testing materials, that has been somewhat of a delay for us, but for all intents and purposes here today, we are in good condition thanks to our prospective action by our materials management group and the leadership to keep us supplied.